from other people's mistake and don't repeat them. So here some of the stalwarts of ophthalmology will be presenting their video where they made a mistake and how they propose, or how the panel will discuss how those mistakes can be corrected, could be averted, and what's the best way to get out of them. So our first speaker is Dr. Saurabh. He's from Bilaspur, and he's a very, what to say, bold surgeon.
Killer intro.
Uh-huh.
That's all.
So I welcome him here, and he's going to present his video. Next, Tejas, you please be ready. You don't have a video? No, 9 to 10.
हाँ जी भैया ऑडियो नहीं ऑडियो नहीं जस्ट 2 minutes Yeah, hi, good morning. Thanks you, Arun sir, for having me here. So I'll be presenting a normal routine, a little harder cataract. I had everything planned as to how to go about it with my, viscoats and everything. So it starts routinely. I usually, inject a dye, push a little visco so that I have good formed visco anterior chamber, and then take a partial entry. So my first mistake, which I realized later, was that my incisions are very close, which made me really difficult to manage the cataract later, is what I would like to show. So as you can see, these incisions have come really close. So Rexis was not a problem. It went off well. There was no issue about it. I did a proper hydro. I am a compulsive stop and chop guy. I've put a lot of viscoat. I have a proper soft shell technique. So the first, I go deep. The key here for any surgeries, you have to have a good crack. So I've been really patient here, that I want to really go down so that, I have my cracks well, the nucleus is rotating well, but you can see how close my incisions are. I don't per se have a place for my chopper to really move well. The second mistake was I am very comfortable using a sort of a, not a very sharp chopper. So here I should have taken a sharper chopper rather than using something what I'm routinely using for usual all my cataracts. So once I have this complete crack here, I thought my surgery is perfect, everything is going fine. I go with my first piece, make my cracks, take it out. But it gets difficult after I've taken the first heminuclei. This and all, it'll come out fine. I have my cracks, but somehow, yeah. So the first part is okay. I'll just skip this a little. Yeah. So once, I finish this, I go back, put my viscoat, everything comes back. And once I rotate this and start to crack this, it doesn't crack well. It keeps on slipping, So I think the second or the third mistake here was I should have also cracked it when the whole nucleus was there per se, so that, I don't have to struggle here. Here I'm really tumbling, struggling to crack it well. And somehow I know that I am overusing the power, which I could have avoided. And definitely I'd put a stress on the cornea here. So these were my mistakes. Thank you.
Saurabh, if you are doing a horizontal separation, then you need your side port and the main port slightly apart.
That's what. Yeah.
But if you're doing a vertical chop, if you are, so you need them close by.
Uh-huh.
So I think your technique was the horizontal separation. So that's why, had it been a
A vertical chop. Yeah.
the side port
Yeah,
was at
yeah.
the perfect location.
Yeah.
It's one thing I always tell all my residents not to do over hydrodissection, not do over rotation. Because
Correct.
some amount of
Yes.
friction should be
That's
there,
true. I
so
get
that
it.
it doesn't tumble and
Yes, sir. Yes, sir.
and
Yes.
try to avoid aspiration of the epinucleus if it is coming before the nucleus. So
Right.
we can
Have that space there so that you know
Space
can
there,
come.
yes.
I get it, sir.
Yeah.
Yes. Thank you.
Your comment, Gulam Ali.
Such harder cataracts.
So your comment, Dr. Singh. Yeah.
Chondroitin sulfate based OVDs are a boon in such cases.
That's true, sir.
They
That's
really
true.
help a lot.
Really.
No uveitic reaction, no corneal reaction. That should be used liberally as you have
Absolutely, sir.
Yeah.
That is the
Well,
way
that's
to
the
go
key.
about it. Yes, sir. Thank you.
Thank you, Saurabh. Now invite Dr. Gulam Ali for his video.
And I would like to congratulate Dr. Shonu for wonderful show. Basically, I'm going to discuss the case of the floppy iris syndrome done by my fellow. One of my fellow came to me and told me, "Sir, I want to do the neck surgery." I asked him why. What is the case? She said, "Sir, 85 years old man with the age-related cataract. He has no other ocular finding. Sorry. He has no other ocular finding except small pupil. He has been on the Urimax tablet for last 3 years for symptoms of the BPH." Then I said, "Are you confident enough?" She said, "Yes, sir, I will do." Then she started surgery. She did, flexible translimbal iris detected beautifully. And she did beautiful rhexis, and she performed excellent hydrodissection. And completed phacoemulsification by direct chop. After completion of phacoemulsification, she noticed the plate of epinucleus. She tried to remove it with the phaco, but due to the shadow of drape, she was unable to remove. Can I do? From where? From where? नहीं आ रही कहीं बारिश में। इसको मैं बोल करता हूँ। Yeah, exactly.
यहाँ से कर।
Okay. She decided to remove the epinucleus by visco expression. Here she did the mistake. So never on learning from this mistake is never overinflate the anterior chamber in floppy iris cases. Then second mistake she did is that she tried to reposit the iris from the same incision. So learning from this mistake is always reposit the iris from the side port or another incision. Here I repeat again, the learning from these mistakes are always to put the eye drape properly, never overinflate the anterior chamber, never insert prolapse iris from the same incision. Thank you. And lastly, I need your support for my candidature for member of scientific committee AIS 2023. Thank you.
Great video, Gulam. So basically a difference in pressure underneath the iris and over the iris, it usually leads to the prolapse of iris through the incision, because that is the path of least resistance the iris finds and it comes out. So to reposit, you need basically two things: to decrease the pressure underneath the iris and increase the pressure over it. So, and that's of course a very good learning point, that don't reposit the iris through the main incision, go through the iris, go through the side port and pull in the iris. It is better to pull in rather than pushing it in. If at all you have to push in, use a viscoelastic to push the iris back into the anterior chamber.
Howard Fine said that any non-dilating pupil should be treated as IFIS.
Yes, sir.
So in such an old age and patient on anti-prostate drugs. Now, knowing that this could be IFIS, the good thing that was done is iris retractors were put beforehand only, not when you were actually seeing the IFIS or you have done the CCC, then it's very difficult. Only thing, one thing is the orientation of the iris hook.
Yeah.
In such cases, when you're expecting iris prolapse, the main incision, the one of the iris hook should be below the main incision. And because it is posteriorly situated, and the main incision can be more corneal, so that the iris will never come in the main wound, because the main wound is the larger wound. Through that the iris can come. Secondly, when we push any viscoelastic, as Dr. Arun said, if you push it in the center, it will go behind the iris. And always use a cohesive viscoelastic at the wound, so it just presses the iris where it is cupping into the anterior chamber. And epinucleus cannot be expressed with the viscoelastic in such cases, because iris will definitely come. It should be done with
I
IA
think you
or
should
with the
lift the epinucleus by visco and then,
and then
remove
just,
with the vacuum.
Yeah, yes.
Yeah.
I think it would, otherwise it was a very good surgery.
Yeah.
Helps a little in this. And the other thing is, if you remember in ERC, I forgot who somebody mentioned there, that when you put the iris hooks, put in a little bit of intracameral pilocarpine. I've tried it in one case. What happens is the pilocarpine keeps the iris stretched, so the tendency to come out decreases, and you have the iris hook, so the pupil actually cannot constrict. It sounded a little odd, but I've tried it in one case and it actually helps. It keeps the iris stretched
Hmm.
and it doesn't
So
tend to.
that is, I feel that that's recommended once you're using a Malagrange ring, because it has 6 or 7 points of contact and it doesn't allow the pupil to constrict. And yes, they say that that keeps the iris stretched, taut, and the floppiness goes away. But I haven't, I don't have any practical experience. Your take, Saurabh?
Yeah. Uh, One point as regards the atropine, the latest trends show that whether you start atropine or not is not going to help. So you don't have to stop the Urimax, you don't have to start the atropine, because males will land up in late night with that problem of urinary retention. So that is one possibility. Secondly, uh, uh, Phenocaine Plus, which is a cocktail of phenylephrine, tropicamide, and xylocaine, should be used as frequently as possible. So you can use it multiple times. And once your IOL is in place, then pilocarpine is a great adjunct. That settles the case.
But in these cases, Pheno can work.
Oh, yes, yes, great,
Yes.
great. See,
But-
these are all alpha antagonists. So you basically need an alpha stimulant, which is phenylephrine.
And in your case, I don't think there was any use of, there was not required. It was not required because the pupil was sufficiently
Sufficiently
dilated. But yes, that's a very good perk that you can use it, use Phenocaine as often as required.
In fact, in floppy iris syndromes, it's recommended that don't use iris hooks, use a Malugin ring or a BX ring.
But Malingering in Malingering, learning curves more, I think.
I
For the
understand.
beginners, it's
Yes,
very
yes,
difficult to put the
definitely,
Malingering.
definitely.
Thank you, Ghulam Ali. I'll call upon Dr. Saurabh to present his case.
And always avoid the, the temptation to do a sphincterotomy in such cases, because the floppiness will just go haywire and all the iris will come into the picture.
स्टार्ट कहाँ से करना है इसी से है ना हाँ। Space button. Good morning, everybody. Thank you, Dr. Arun, and for inviting me on this podium, and Dr. Sonu for this wonderful event. Here I'm going to discuss one of the mistakes that I made about a couple of months ago. I was dealing with a polar cataract, and despite all measures like a good rhexis, mechanical hydro-free dissection, slow motion phaco, and visco exchange during all steps of surgery, this is what I encountered. Now here I'm preparing to implant a hydrophilic lens into the capsular bag. It's a multifocal lens, and though this lens is a hydrophilic, it doesn't fold very gently. But once I implanted it, this is what I saw. A large triangular PC rent was staring at me. And this is the time I realized that a case of polar cataract is not over till the surgery is over. And so I thought of revising my strategies to do such cases. So here's another typical case of polar cataract, a 35-year-old gentleman. And here first we need to have a thorough preoperative evaluation. We need to differentiate between a localized posterior subcapsular cataract and a typical polar cataract with all the typical findings that we know, like onion skin and all that. Doing a perfect rhexis is very important. You can imprint the rhexis mark onto the cornea with a rhexis marker. And it's also very important because in this case it's important, but more so it's important in case you have a PC rent. So you can use your anterior capsule to capture the IOL once you have encountered such a problem. Now, as far we all know that hydrodissection is contraindicated in such cases. So here I have opted for a mechanical hydro-free dissection. And here I used a thin iris spatula and went 360 degrees to free the cortex from the anterior capsule. The slow motion phaco technique was used. And basically, the important part out here is the parameters that we're using. It's a very low IOP of 34, which works out to be a 54 centimeter bottle height, an AFR of about 30, and a vacuum of about 320 to 350. So it's a slow motion phaco, and I'm working from the periphery towards the center to remove the polar cataract in the last part of my surgery. Now it's consumed. And very importantly, visco exchange after each step of surgery. So you do not want the AC to collapse. So here a visco exchange was done. A bimanual IA is obviously the preferred technique because it gives you access to 360 degrees. And plus, it's more safer as compared to the coaxial, but there's a difference of opinion regarding that. Now here, the main thing I have learned from my previous mistake is, here, while you're implanting, use a hydrophobic implant, preferably an implant which opens very gently into the capsular bag. In case you're not very sure of the opening, use a cohesive viscoelastic, because a cohesive viscoelastic is basically expandable. It is very gentle on the posterior capsule. And here we managed to finish off this case. In the end, also, please resist the temptation to remove all the viscoelastic behind the lens with a hydrodelineation or a hydrodissect, because that itself can rupture the posterior capsule. So be very gentle. Visco exchange is very important. Use low pressure, low fluidics parameters, and I think low pressure, low fluidics, and being watchful throughout the surgery is the way to go. Thank you so much.
I think the point is very well made that even if you don't get a obvious rent in a polar cataract, once you have finished the cataract, the capsule is very thin and fragile, and it's going to rupture with even small maneuvers like a hydrophilic lens insertion. So yes, you're right. Cohesive viscoelastic should be used. Preferably a hydrophobic lens should be used. I've had a complication in which everything went off well, visco was removed, I was hydrating the main wound, and then the rent occurred.
Absolutely.
So even the excessive pressure in the anterior chamber can cause a rent. So you have to be careful. Nowadays, the rent with an experienced surgeon, the rent is more after the cataract is over, because then you relax.
Yeah.
So there's no time to relax, even till the last, when the speculum is removed, then you can relax. I think that is the take home message.
It's not over until it's over.
It's all over.
Yeah. Thank you, Saurabh. I'm calling upon Dr. Pankaj Sharma, professor at SMS Medical, professor and head at SMS Medical College. And let's see his video. He's a prolific surgeon, and he goes by the book.
No, but I didn't go by the book in this.
Okay, he's the book.
And why?
He's the book. Gaurav, you're next.
This is a very, very silly mistake, and I hope you don't laugh at me for this. I'll tell you the reason for it. Okay. So this was one of those days I had a very long list, and after 3 hours, I had to go and attend some meeting. This was the third case. First 2 cases went off very well. This is the third case. Everything is okay till now. And I'm saying to my assistant, Joe, give me the sodium hyaluronate. I have to put in the lens. I'm in a hurry. So it is actually the tram car effect. Jab ek bogie derail hoti hai, so it pulls all the bogies along with it. And all your rational thinking goes for a 6. That's what happened with me. So the first mistake, I didn't tighten see what happened. I didn't tighten that cannula. I always do it, but I didn't do it at that time. And Murphy's law came to this thing, and see, because it is screwed like this. So it was loose and it unscrewed and it went into the vitreous. I immediately removed it. So the first bogey derails. Now I think it's a small defect. I can still push the lens in the bag by, pushing the cohesive OVD from one side. Now my mind has stopped working at all. So I slightly enlarged the incision so that, it's not a, a traumatic insertion. Put in the hydrophobic lens into the bag and try to dial it into the bag, just hoping that no vitreous is there. Because in back of my mind, I have to finish this case. So the first loop goes into the bag. Second, I just try to just maneuver. Now, the place where I'm putting the second loop is where the rent is. So I try to dial it, and I think it's okay. But if you just see carefully, the lens is slightly tilted. I just ignore that. I feel it's okay. I'll just remove the viscoelastic, not putting the IE cannula, with just a wide bore cannula. This is the third bogey. I'm totally off now. I'm trying to remove the viscoelastic, and now I see, oh God, there is vitreous. Still, I can't, think normally. I think, okay, what I'll do is I'll remove the lens from the bag and put it in the sulcus. So that now the train is going totally off track. I'm just telling it, just prepare the next case. This is almost over, but it's not over. I'm trying to bring out the lens into the anterior chamber and trying to, put it in the sulcus and just close my eyes to the vitreous. I hope everybody has had such a event, but I feel very silly showing it. So now I try to put it in the sulcus. I realize it is not going to work. Still, I do one last ditch effort. I'll just put it in the sulcus and just close down everything. Now watch what happens. Finally, I'm successful in putting the lens into the vitreous. So that was my aim. So here it goes, the one of the loop. Now, because the rent is all very large now, and it has half of the lens has gone into the vitreous. Then I said, okay, now let's wait. Let's not waste more time and do it the proper way. So what mistake was done, which I did was, I didn't do a vitrectomy at that time because I knew there was vitreous there. When I put the viscoelastic, it wasn't going in. So then I make two ports, enlarge the one of the side port, make another port on the opposite side. So never do vitrectomy from the same. Preferably, it should be done from the pars plana route, but I couldn't think properly that day. Finally, my kidney starts to work. And I scratch my knee and everything goes well now. Just a limited anterior vitrectomy. Remove the vitreous which is there in the anterior chamber. And look, and after that becomes so easy. The lens gets dialed into the sulcus. The IOL gets captured into the anterior capsular rim very well. It is very well stabilized. Pupil becomes round. Limited way, you can remove your viscoelastic. Now it is dialed into the sulcus, and with the iris hook, I have with this the dialer, I have now captured it into the anterior capsular bag. Now it is all right. Pupil is round. There is no vitreous. So that is the mistake I did. Thank you.
All's well that ends well.
Well, Dr. Pankaj, it is really courageous of you to show these things here. We all know how meticulous are you, but I fully agree with you that there are days and times when you lose your sanity actually, and you just shut off your gray matter and you do whatever should not be done, and it happens with everyone.
So I think I wanted to show this so that don't try these things. You may be a good surgeon, but vitreous is can defeat you anytime.
Absolutely. So I think cannot agree more than
So you have to respect vitreous. The moment you see it, the takeaway point is that you must first deal with that before going to the next step.
Dr. Pankaj, I must congratulate you.
Thank you.
Most of us would have passed it off as done by my trainee and done by
No.
and all that.
I did it.
But all of us have gone
Back
through
of
this.
my mind, I had to finish My
But
cases.
I would say one of the take-home messages is that there are no shortcuts in surgery.
Yes.
This always happens when you are in a hurry. There is something at the back of
Yes.
your mind, somebody waiting,
Yes.
something to be done outside. That is the time you try to make shortcuts.
Yes.
And the mind stops working that if I do this, it is going to take longer.
Yes.
Let me just do it the faster way.
So it's penny wise, pound foolish.
Exactly.
Trying to save 2 minutes, it takes 20
It takes
minutes.
that much.
Right.
And like you very rightly put it, that tram car effect, then one thing leads to the other.
Yes.
But a very, very wonderful presentation.
Thank you very much.
Thank you, Dr.
Any
Pankaj.
other?
It's a great video from somebody whom I've learned FACO through. So hats off to you for showing this mistake. Just two things that I'd like to add is one is the tricot
Yes.
would have been
I knew
better.
that was going to come up.
Yeah,
End of
yeah.
the surgery.
And secondly is the lens which is in the sulcus. So the haptics might irritate
Yes.
and cause uveitis.
There's a hydrophobic lens with a square edge all around. So it can cause uveitis. Tricot, yes, it should be used in all cases, but being in a government setup, sometimes it is available, sometimes it's not available. So I had to do with that. Thank you.
Thank you, Dr. Pankaj. Now I invite on Dr. Gaurav. Okay. I'll request Dr. Mukesh Sharma to present a certificate of appreciation to Dr. Pankaj. नहीं वो जो कैनुला क्या है ना वो उसका आपने
वीडियो है
ऑडियो भी चाहिए हाँ ऑडियो दे दो ठीक है
अभी कुछ नहीं बोलना है नेक्स्ट ओपीएल में इज yeah.
So after that really nice video from Dr. Pankaj, I was trying to find something where I would, maybe look like a fool, but let's see, I'll make an attempt. So this was a gentleman who had been nurturing this cataract for almost 6-7 years with us, because he had lost his fellow eye to detachment, which was operated 2-3 times, and he was once bitten, twice shy. This eye also had a vitrectomy done before, and with an SOR and everything. So his cataract, we saw him go from like 612 or 618, and gradually over 5-6 years come to about like finger counting. And finally he was ready to get operated. But because it's a vitrectomized eye, there was also significant amount of zonular weakness, and there was phacodonesis, and it was more like a sclerosed kind of a cataract. So in retrospect, the first thing, as I started, I realized that I should have gone for a femto-assisted surgery here. It would have been ideal because I would have had a great rhexis in place. It's a shaky kind of a lens. So at the moment I started, I realized that the first mistake was that since I do have access to femto, I should have definitely done a femto. But anyway, so once I started doing the rhexis, it was a sclerotic kind of capsule. I somehow, didn't have great control on the rhexis, but managed to complete one. But in the process, I ended up getting a small rhexis. So this was mistake number 1. And even at this point, if I probably wanted to enlarge the rhexis, I should have, because it's a very hard cataract. It's a shaky lens. It's moving all over. I've supported it with capsular hooks. And you can see that in that lateral separation, there is all the risk of that rhexis going to break any time, because while this is an edited video, I had to be very, very patient, because the visualization was not great. He's a one-eyed patient. There's no PC support. So anyway, we kind of somehow managed to get that nucleus out of 4 mm or even a slightly smaller than 4 mm rhexis. And at this point now, I was left with a capsule which had huge amount of plaques. So 2 mistakes already done, small rhexis, and even at this point, maybe if I had enlarged the rhexis, but I decided that I'll try to clean up the bag. And you can see how badly stuck this is. So again, this is like edited and fast forwarded. So I had to really struggle to even clear one clocar of cortex, which was stuck, and the plaques, which was stuck to the PC. And of course, there was that big plaque staring at me right in the center. But even getting things out of the equator was very challenging, because there was almost no zonular support. And I wanted to put in a CTR, and maybe in retrospect, again, that's the third thing. I should have probably put a CTR at this point, but I was worried because I wasn't sure that this bag is going to survive. And if I put in a CTR and I have to later on sacrifice the bag for some reason, and then getting the CTR out may be challenging. So I wanted to keep it till the time that I really need it. So I went on. Now, since after working for almost 5-6 minutes, I could only clear up like one quadrant. I decided to change tack, and I decided to go with my other technique, which I've been kind of propagating or whatever, championing, is to do a jet wash. So what I do is that I have these, hand blasted cannulas, and I use the infusion from the main port. As I think yesterday Mayank was saying, or I don't know, Dr. Mukesh was saying, I'm not sure, somebody was trying to tell me when I was doing live surgery, that why don't you do that? So this is what I do. This sets up a very fast flow inside the eye, and you can go and run the fluid and also use the polisher at the same time to loosen up everything in the equator of the bag. And it works like magic, because it just loosens up everything because of the two things that are happening at the same time. Plus, it's very safe because, as the fluid is running, it will never go and break the PC, because, constantly the PC is pushed away by the flow of fluid. So you can go polish nicely and loosen up everything. And if you remember that everything was very nicely stuck, but now everything has been loosened up with that fast flow of fluid, which I call it as the jet polish. And it just kind of makes life so easy that now you can just go and aspirate almost everything. Everything is loosened up nicely and separated from wherever it was stuck. So I've managed to do most of the work now. And the story is not yet over, as Dr. Pankaj was saying. I still have to remove this plaque. And since it's a vitrectomized eye, the capsule is very flimsy and friable. The bag is very flimsy, and any kind of forces will cause zonular dehiscence to happen. So I'm peeling it somehow, and visualization is not great. This is a high myope that we are dealing with. So the chamber is very deep, and you can, you have to hold your breath and try to see whether you're going to get it or you're going to get a PC break. And sometimes in these vitrectomized eyes, if you get a PC break, it's a very friable capsule. It'll just behave in a very funny way. You may not even get a chance to make a proper rhexis out of it. So, and the whole success of the surgery hinges on having an intact bag. Otherwise, the whole effort will go waste, and then I have to go for a glue dial or something. So finally, I was able to get a hold onto it, and with a lot of manipulation and changing of hands and changing of direction and everything, finally it does come off, and I have an intact PC there. And now I'm thinking that I'm victorious, and all I have to do is go in with my lens, all set. I just see that small little thing there, and I think that I should remove this also. So I'm sorry, this is a editing mistake. So we are back, and now I just go there, and now this is the moment which everything goes for a 6. All that effort of almost 30 minutes of doing the surgery. Just see where I should have gone from this side. I'm using my bimanual, but being instinctively a right-handed surgeon, I use my aspiration port, and I just move that rhexis out a little too much. So I completed everything, and at this moment I break the rhexis. So there goes. And now I'm sitting with a broken rhexis. I can't put in a CTR anymore. It's going almost to the periphery. And so this was mistake number 4 that I made, in spite of all my best efforts. So finally, anyway, I am going to go ahead, but I'm not going to put a toric lens anymore, because the break in the rhexis is exactly in the axis where the toric was supposed to be implanted. But I will get the lens into the bag and manage to position it in such a way that it's not going to cause any problems there. And finally, I was able to kind of finally finish this surgery and save the day for the patient. Patient is doing well. This is about a year or 2 back that I did it. I do this trypan blue test to look for any leaks. So lots of lessons for me, and I thought this may be an appropriate video to share with you all, and I'll be happy for any more tips on what I should have done and at what stage.
Thank you, Gaurav. Excellent video, excellent tips. What would I have done differently? I would have used maybe an AC maintainer or irrigation in a vitrectomized eye. So the iris lens diaphragm, it's unsupportive. There's no support underneath. So you may go and use a AC maintainer or a irrigation cannula through the pass plane as well,
Right.
because sometimes that helps.
Absolutely. I agree.
Yes, but sometimes that may also create problem if the day is not yours, because in these eyes sometimes jonules are deficient at one corner or so, and if you put in lot of fluid inside, then that fluid itself may rip it off. So I think as a whole the case was very nicely managed. There were a lot of problems which you could overcome, and I think cohesive viscoelastic plays a great role in these eyes.
I think in retrospect, my first tip would have been femto-assisted surgery. You know, if I look back, I would have done at least the rexis, if nothing else. That would have given me, I mean, most of these things would have been avoided. If I had just done that, I would have just got a clean cataract, put in a CTR and put in the lens. Yes, Tejas?
This surgery did on 14th of February. You know, if you look at the shape of that rexis, it was something like that. Why did you not enlarge at the very first
Also,
instance?
so the thing is that, you know, as I was even making the rexes, there was so much of stress because it was a thickened kind of sclerotic capsule that, you know, it was like, it was ready to give way at any time. So the very fact that I managed to get a rexis was good. At one point, it was looking to me that, you know, even the rexis will not be a continuous proper rexis because some of these capsules are not very healthy. Anurag wants to say something.
Two things that I have done would be back removal and then getting rid of cortex, which is left over. I would have done both of these procedures after
Putting the IOL.
Support with the lens stretching out. And if not, in other cases also, these cases actually have very parallel capsules that you rightly mentioned. When I'm going underneath the anterior capsular red, given a short strip of cortex, I would have removed the capsular whisker. When they are vertically stretched, they are always more likely to have a radial tear.
You're right. In fact, when I put in a CTR also, I usually take out the capsular hooks. I just leave maybe whatever is absolutely essential because even capsular hooks, you know, interfere sometimes with the CTR. And you're right. My idea was to implant the lens and then enlarge my rexis. I almost always do that because I try to run it just along the inner edge of the optic, because otherwise these are the eyes which are also very highly prone to capsular back contraction syndrome. So, and they will increase the, you know, chances of getting a future back dislocation. So I would typically do that and put in a CTR. So that was the plan, but everything went for a 6 the moment that rexis broke and effort was wasted. So.
So very nice video. I would just ask you, why did you use that kind of utrata, that kind of capsular rexis forceps? Because the forceps tips were pretty bulky. They were, I think, we have finer.
I would have thought it's a micro rexis forceps. Let me just go back. So it's a micro rexis forceps.
That basically,
And
The one that is, I mean, like by epsilon people for the posterior rexis one. But the finer ones would have, you know, made your job easier.
Probably. So this is actually a micro forceps. It goes in from a 22 gauge side port also. But here, because there was good amount of viscoelastic, I'm going from the main port. But yes, I actually, it's just probably because I'm very comfortable with it. I like to do my rexis from a side port. And usually I would use this for all my other maneuvers, like, you know, so whatever instrument you are comfortable with, you end up kind of trying to use that. But a regular utratas, I don't use anymore at all.
Okay.
Because
so
you have
only.
Yes, I usually, even if I'm going from the main port, these forceps will not open the side port. I mean, the main port too much. So the visco egress will be very little. So even from a 2 millimeter incision, if you're using something like this, you are not depressing the posterior lip much. It's not opening up the, you know, so the chamber stability remains a little better.
So what viscoelastic do you use for rexis?
For these, for such cases, I use viscoat. I like
for routine cases.
For routine cases, HPMC. Yes.
Okay.
thank you, Dr. Dhawan. They just, Sonu needs to go somewhere. So Sonu is coming in next.
Arun, may I add a word?
Yeah,
See,
sure.
half the time in cases like this, Gaurav, I think your subconscious actually tells you that this is the time probably you must enlarge, and the ego comes in the way and you say, I've handled so many cases, I'll manage, let's see, ho jayega, kar lo. But most of the times, normally, I think you should listen to that subconscious thing which comes and says, okay, stop and go ahead and do this.
Only when I started doing the job. You know, till then actually it was not really, I mean, it did not register, but when I went in and did the first job, I realized my rexis is too small. But by that time, you know, it was a little too late for me to go in because it's all messy and you can't see things so well. So I had to then go ahead.
The rexis is being held by your hook. You can definitely go ahead and enlarge it. That is also a good test.
Because it can run away.
No,
I would have to.
no, you can't do a rexis with a taut rexis margin. Yeah.
I said that if the hooks were there and hooks were being held by the rexis, that means there was enough exercise that you could have made a bigger rexis and then done the entire procedure.
But with the intact capsular hooks, how do you do the rexis then? I mean,
I'm saying that the hooks were a testimonial that this rexis is good enough. ring can be still extended because we were holding the hooks also.
So I think it was a wonderful video presentation, and what actually happens is, you don't realize. So that is very important. So Arun has asked me to talk on subluxated cataracts. So this is one of the ways that we handle subluxations in our settings. And if you see here, this is one of these young guys who has these zonules almost absent 180 degrees. So this is one of our preferred techniques, and I usually do 2 side ports. And quick tips, learning tips here, a good viscoelastic, which actually temporages the vitreous from coming anteriorly, starting of the anterior capsular rexus. You have to leave a peripheral rim here, because this peripheral rim is what actually gives you support when you're using any anchor devices. And this rim is very important, because otherwise any ring, whether it's a Cioni or you use any Emmett segment, this would slip off. So good capsular rexus, which is round circular, is important, hydrodissection, and just separation of the cortical matter. This is just a very soft lens, just irrigation aspiration. And just watch my left hand. This is always trying to inflate the bag. So this actually prevents the hydration of the vitreous, keeping the bag taut at most of these times. And I will not withdraw. I will not withdraw my irrigation till the time I have, just watch, till the time I have viscoelastic in my right hand. And I would just try always to inflate the bag here, because the moment the bag collapses, you have all the more chances that the bag might come up and you have almost a dialyzed bag coming out of the wound. So just watch carefully. The viscoelastic goes on, the irrigation is off at this moment, and I'm trying to distend the bag. So this is one key step when you're dealing with these kind of patients, because the bag has to be intact, distended. So I go through the main port, and one quick pearl that I learned from Gaurav is that you have to use a CTR with an injector system. See how cool this goes in, and circularly it moves, and you're right there with a 360-degree rexis inside the bag. So this is one very essential thing which you can actually make out where the ring has gone, and you don't try to actually disrupt the already weakened zonules. You try a number of times just pushing a CTR, and actually it's a very a crude way to insert. So I think the injector system is the preferred thing. So what we're doing is we're trying to create a Hoffman pocket here, and always distended the bag. And my preferred technique would be the lasso here, where I use the 8 or Gore-Tex. I just 2 markings, 2.5. This is the Emmett segment, and this is the Gore-Tex suture, which is just threaded. And these are the 2 ends of the Gore-Tex which need to be externalized through this loop. So we have created a loop by passing an 8 or Gore-Tex reverse inside the 26 gauge. And now just this is the loop which I'm talking about. This loop is externalized, brought out through the main wound here. Watch carefully. So I just pull it out, and one of the loops, one of the ends of the thread which has been passed through the Emmett segment is passed like this, and gradually pull. So it is just like a loop which is trying to pull one of the ends out. So this gets externalized now. And now this is the second loop which comes in. I just slowly pull this off, and the second end thread is just looped in, and this is gradually externalized. So very atraumatic, non-invasive way. And this Emmett segment is then pushed inside the bag. Very carefully, I nudge it. And this is what the margin I was talking about. So if you have a good margin left over, this would never roll upside, pop out. So I gradually withdraw this here now, and I just watch carefully, 8 or Gore-Tex through this. And I then pull this through the Hoffman pocket here. And 8 or Gore-Tex has to be underneath partial flap of the sclera, so that it doesn't, cause that granuloma kind of stuff formation. And this has to be buried most of the times. So this is my job is done here. Now I push in viscoelastic, a 3-piece hydrophobic acrylic foldable IL is the lens of choice. Just in case if I lose the bag, I can always do a Yamane, or I can switch on to a glued IOL technique. So very carefully, I nudge it inside the bag. And then looking into the 3 Purkinje images of the Lumera microscope, I try to centralize this lens back complex. So now watch carefully as this is nudged inside, and then I'm trying to tie this. And the strength depends upon the centration looking into the 3 Purkinje images so that you have an exactly centered lens back complex. So very carefully, I titrate and then 3 to 1, just flush this and just push it inside. Now, this is what gives you a very good cosmetic day 1. Viscoelastic wash is essential. You can always do a triamcinolone stain if you feel there is vitreous in the anterior chamber and do a good anterior vitrectomy, hydro sealing of the wounds, and very carefully, whatever the retained viscoelastic wash can be done. And you have a very stable lens back complex day 1. And this is the day 1 post-op picture. And this is how we've been dealing. Yes, but a lot of pearls that I'm sharing is through our own mistakes that we have done over these years. And I think that what makes you, a little more careful once you do all these surgeries. So thank you very much.
Excellent surgery. Excellent. Mesmerizing. Your comments, Dr. Mukesh.
I don't think you could have done anything better than this. It was really wonderfully managed. Doing Rexes in these eyes is really difficult, which you did with perfection. And then you did everything well, I think. Very nicely managed.
Thank you.
Just one comment. Dr. Sonu, you inserted a CTR. The dictum says that your eyelids of the CTR, they don't go to the place of zonulodialysis. They should be at the place where the zonules are intact. So you could have rotated your CTR in such a way that your eyelids were away or 180 degrees away from the area of zonulodialysis.
So I think that's a very important point. That's a very valid point. But as you saw, when I was injecting, there was no shakiness. So whatever the intact zonules were, they were quite strong. So this was probably a young guy with, intact or maybe non-compromised zonules. So, and I think that's a very important take-home message that whenever you're doing a phaco and you have a bag dialysis during that procedure, you distend the bag and always you try to push it from the opposite side. But actually the injector system, goes through the main port. So then you have to actually titrate whether you want to go 3 or 9. So whatever the clock hours you want to do. Yeah.
I think Dr. Sonu has run out of videos where he has made mistakes. So this was perfectly done. Very nice. Excellent.
Thank you.
Thank you, Dr. Sonu. I call upon Dr. Tejas now for his video.
Hello. Yeah. So good morning once again. I am going to just run the video and all of you tell me what mistakes I did at the end. Let's keep it that way. And उन्होंने copy कर लिया वहाँ पर. Tejas, हाँ. कोई नहीं. That's the So these were the days where multifocal had just come. And I was always very excited to offer a multifocal to all my patients. In fact, audio, but audio नहीं volume coming. And I was so much on cloud 9 that because I used to be a trainer for the restore lenses, I used to be the certifier. And so this is a young patient who presented to me, and frankly, I had not seen him before the surgery. We are in a group practice, and he just landed up on the OT like this. And so I said, let's go ahead with the multifocal implantation in spite of a small pupil, and give him a good visual contrast with a pupil which is quite mobile. I didn't actually want to use any instruments or device to stretch this pupil, because ultimately it leads to a not a very pleasing sight on the day 1 and later on also. So it is very easy to do the rexis beneath the pupil, because usually the rexis does not run away. But well, at one point of time, this is an edited video. Probably I touched the iris. and the pupil came down. So this was an intraoperative pupillary meiosis. Now, I was in two minds what to do. So like I said, on those days, rather than doing something which you would want to do, I stretched the pupil. And this is also a very effective way of keeping the pupil away from the phaco probe and trying to visualize where your phaco probe is going. And ultimately, well, I could finish the entire phacoemulsification. Without using any external devices. Well, it becomes a challenging situation, but well, this is what I had actually put myself into, doing the irrigation aspiration, trying to make sure that entire each and every fiber of the cortex is removed. You need to keep visualizing by pushing away the iris. And then comes the most important reason for this surgery, the implantation of the posterior, of the progressive lens, or the bifocal lens, or the multifocal lens. I'm just trying to make sure that the leading haptic has gone in the bag. Because if that has gone in the bag, then your job becomes very easy. You just need to push the trailing haptic with an intact capsule. This also is very easy. So those were the initial days of Restore. I think 2006-07. And this is what actually I ended up with. Great. So what mistakes did I do? I'm asking you.
Well, one thing is that one should not commit for multifocal IOLs in these kind of pupils basically, because any abnormal size of post-op pupil would create optical
Absolutely.
problems. So I would always tell my patient before attempting the surgery, if everything goes well, then we shall implant multifocal IOL. Otherwise, we may resort to a monofocal IOL.
Absolutely.
So I think that's the only thing. We may think of using pupil dilating devices also in between the surgery whenever you feel like.
Exactly. And that's the reason, if you go back to my first comment, those were the days of excitement. Multifocal patient, and we would also jump. And like I said, I had not actually seen this patient preoperatively. Otherwise, I would have also tried to make a plan B. But here the patient ends up, and you know, premium patients in 2005-06 were like, God, oh, this is a 75,000 package patient, and said, I will go ahead and do it. So yes, that was a plan. That should have been a plan B. That if not needed, if needed, I might not put a multifocal lens. Great. Any more mistakes that I made? Dr. Pankaj.
No, you didn't make any mistake. It was an excellent surgery. But I think the pupil expansion device has been used in this case.
Yes. So,
And once you have committed the CCC, then it becomes extremely
easy.
difficult to put in the expansion device. It gets caught in the CCC
absolutely.
margin.
But somehow that's my school of thought, that rather than implanting all these devices, if you can manage to finish the surgery without them, it's always better, because ultimately I was also thinking at that time that I want to leave the pupil pristine as possible. Don't want to go ahead and have much of a damage to them, which
Even
usually
at
happens.
the end of the surgery, the pupil
It happened.
was irregular.
It
slightly.
happened. That's what I
Yes.
said, that it happened. Yes. And that's the reason Dr. Mukesh's comment, well, we could have gone with a monofocal also.
Yes.
Thank you.
So in those days, it's excellent surgery. The only thing is, if a this is not used, phaco is still easy because phaco is a central procedure. But irrigation aspiration is very difficult. And there you might catch the anterior capsule or the posterior capsule or the iris. So pupillary expansion device helps you through the entire course of surgery.
Very true. Very true. In fact, pupillary device is definitely going to help you. But well, I was in two minds whether to have a damaged, because we were committed for a multifocal. We wanted the pupil to be as pristine as possible. And majority of times I can manage that. I have other videos also to show. On that day, probably I was a bit lethargic, but I touched the iris. And for me, during a phacoemulsification, not touching the iris is my first fundamental. That's why.
Thank you, Tejas.
Yes.
I call upon Dr. Namrata Sharma for her presentation. Dr. Namrata needs no introduction. She is Secretary AIOS right now, and she's going to be the Chairman Scientific Committee from the next term. Okay, your video is ready? Yeah,
Okay.
please.
So I'll be showing you two cases, and I thought I'll show you this video first, but then I realized that there was not too much to learn here. But then I'll just show you. This is how flap motility sign on intraoperative OCT looks like. So this is what we are trying to do, demonstrating that we are making incisions here and seeing that there is no posterior polar, which you can make out on the intraoperative OCT. So again, in this case, the incision is made and the anterior capsular rhexis flap is being elevated to make the capsulorhexis. Again, after making this, the hydrodissection is done. There was nothing much to it. A nuclear emulsification is then subsequently being done. And then after doing the nuclear emulsification, irrigation aspiration is done, followed by the intraocular lens implantation. The PC is quite intact, as can be seen here, and there is no problem as of now. And as the lens is put, notice that while putting the lens, the edge of the lens has actually caused a nip in the rim of the anterior capsule. So there's an inadvertent tear on the capsulorhexis margin, which can be seen here while putting the lens. And actually, you don't realize that this can occur, but sometimes it does occur, and one has to be careful. And as soon as this happens, this PC becomes wrinkly. Otherwise, it is quite taut, like I showed you earlier. It is quite concave. But this kind of becomes wrinkly as soon as there is a tear and that trampoline effect of the capsular bag is gone. So you're trying to place the haptics perpendicular to the tone edge, because thankfully it is a spherical lens. And then you can see that these are the two edges of the flap which have actually given way. And this is what has been described by Dr. Rohit Om Prakash as a flap motility sign. And you can actually see these flaps here, and it has not gone posteriorly. And this is what it should be, that it should not go posteriorly. So this was to show one, and I think second is a more interesting case. It was a developmental cataract. So if we see this is how the nucleus is looking like, classically a developmental cataract. This is not a senile cataract. It is a young patient. You can see the nuclear layers also there. Then capsulorhexis was done in this case. This was a toric intraocular lens. Nuclear emulsification was done. Again, there was nothing much to it. But what happens sometimes the phacoemulsification surgery goes off well, but you become a little careless while implanting the intraocular lens. And there may be at times the posterior capsular opacification, such as here, there are remnants which can be seen on the posterior capsule. So you have to move away from the temptation of scratching these remnants which are there on the PC. More so in developmental cataract, because you don't know how it will behave. And here I was quite adventurous. I thought this is just a thing which is there on the posterior capsule, and it seemed to come out also with the irrigation aspiration. I should have left it here, but I am still being very stubborn. I thought I'll just, why leave that little piece of remnant on the posterior capsule, although it will, I know, will be possibly not interfere in the pupil. And then it did not come out with the bimanual. And then this is again, I think, should not have been done, because this was the last straw. I thought that just the whole thing peeled out like that from the PC, even this would. And I did leave it, but then in that maneuver, what happened was that that area became a little weak. So as soon as the intraocular lens was implanted, and I think viscoelastic was also less, because notice that there are stria which are present all around, and this lens is trying to go posteriorly rather than anteriorly. So you have to actually look at the haptics where they are, and this is a toric intraocular lens. You can't manipulate too much also, because then whole thing, if it rips, then the toric lens will not be implanted. So I'm doing what is not advised, and that is you are not supposed to move anti-clockwise. You have to actually rotate it clockwise. But then there was no option, because this was done at the cost of minimal manipulation. And notice again that there is a PCR there. So in the IOCT, the PCR looks like a scroll. So here it is, the two scrolls can be seen. And then of course, air bubble was instilled and pupil was pilocarponized. Now on the hindsight, I thought that we could have captured the intraocular lens also. But then at that point in time, because it was a toric intraocular lens and I did not want to disturb anything about it. But if it had been captured, it would have been better, because it would not have moved in the post-op period also. Captured by the anterior capsule.
Maybe use of tricot would have ensured that there are no tags inside. Otherwise, everything was managed.
Yeah, I think the way it went, I feel the vitreous was not disturbed, but I could be wrong also. And I didn't want to touch anything, because I thought if the vitreous phase gets disturbed, then the placement of the toric intraocular lens also would be a problem. Pankaj, what would you say? I know he's not commenting, but would you would have captured, I'm sure.
No. The only thing is I wouldn't have bothered about that small limit.
Small, yeah.
Because again, the same thing, penny wise, pound foolish. Trying to go for that, you create a bigger complication.
Yeah.
So then if a child, we could have I don't know what the age of the child was.
It was this was a 18-year-old.
So we didn't need to go for all that, because it was not in the, and even if it would have come, we would have done a YAG.
Yeah.
So that it showed that the lens remains in the proper, since it's a toric lens. Otherwise,
Yeah. So PCR would have increased if it was captured. No, but lens was already inside, so that was with the hydrojet. Yeah.
Yeah.
No, more so. More so because it was a young patient, I think. She was yeah. Anyway, thank you.
So we come to the end of this session, and we have a very interesting session in the screen one. So we all move there. The OPL is next. Thank you, everyone. Big thanks to all the speakers who could make it and showcase their wonderful videos. Thank you all. I'll request all the speakers to come so that we can have a photograph. Dr. Namrata. Tejas.
Ah. So we'll start with the pentacam discussion. Till they put up the slides, see pentacam basically it is a or pentacam or any corneal topographer. It works on a Schemflug based photography, as you all know. So these are these cameras, Schemflug cameras that catch the major advantage of having a Schemflug camera is that it works on a principle that it gathers the images of both the anterior and the posterior surface of cornea, plus the anterior chamber, also the anterior lens capsule, because in sometimes you have these high resolution models, then they can have anterior lens capsule and also the densitometry of the lens and the cornea. So basically it is measuring all the topographic indices of the cornea and the lens. It is also measuring the angle kappa and other degrees of angle, the antechamber angle. Plus, it is also measuring the densitometry of the cornea and the lens. So what happens is when we measure the densitometry of the cornea and the lens, we can actually know where the densitometry increases, like in corneal scars or in corneal edema. So the densitometry of cornea varies. Also in lens, the densitometry of lens, if there's a anterior lens capsule opacification or an anterior lenticonus, so the densitometry of the lens would also vary. Another advantage of having this is that they have an inbuilt aberrometer. So all the spherical and chromatic aberrations that you are able to actually see, because this depends a lot on when we are planning a refractive management for a patient. So once we have these chromatic aberrations and the spherical aberrations, the bursting or glare of light that you see when you are traveling in the dark, or when you are kind of having these images that you're not able to see clearly, it's because of the aberrations. So all the color differences that you see is because of the chromatic aberrations. So they also measure the chromatic and the spherical aberrations. So here, this is a typical map of, you have pointer? So this is a typical map of how a pentacam would look like. So you can see the first what you have to see is that the name, the age of the patient should be correctly filled, because see all these images that is captured is when you have compared to the best fit sphere to a normative data which is already feeded in this. So if you're not putting the right age or the right gender, then the findings would vary. Secondly, when you're always working, look at the scale. Do you see the scale, the red to indigo scale that you see? You should always see for the values of the scale, because a lot of times we get confused. We have this in mind that red is steep, blue and green is flatter or normal. But actually, when you look, because different topographers, a lot of places they have anterior topographers. So when you would, if you don't pay attention to this scale and you do not see this, then you might get confused, because in a lot of topographers, blue is normal and indigo is flatter, and when you go towards the greener or the yellow side, it becomes steeper. But in these topographers, the pentacam, it is actually the green is normal. But again, check for these scales when you are going through this. Thank you. So then so then you have the most important thing is that you can see both the cornea front and the back, which is very important. So a normal anterior topographer will only see for the cornea front, and you would not get anything of the cornea back. So if it is an early keratoconus, you tend to miss a keratoconus. It's only when it shows in the anterior curvature that you will be able to gather this.
So when we have actually 4 maps that they are actually there. This is you can say it just looks like a normal kind of a map. Why? Because there's the anterior or sagittal curvature of the front, then there's a keratometric deviation, the sagittal curvature at the back, and corneal thickness. So these are the 4 basic maps that any topographer would like to see. And this looks like a kind of a normal map because you have a steeper axis in the vertical plane. So you have, with the rule astigmatism, a steeper axis in the vertical plane. You think that it is normal. But anything which is not steep in the vertical meridian and you have an against the rule astigmatism, always that should be an alert sign to see for the posterior curve. Do not leave this map alone when you have an astigmatism which is not corroborating to the normative data. Again, the superior and inferior asymmetry. This is very important that you see in all the maps that in this map, this is not a normal map. So you see that superior half is flatter and inferior half is steeper. So this is superior inferior asymmetry. And if it is more than 1.5 diopters of asymmetry, then again, you should click something in the mind that this is something wrong here. And we should always see the posterior map also. Okay, then the sagittal back curvature. Always remember back float or the posterior float of cornea is always steeper than the anterior float. So you should, seeing this as red doesn't make you believe that this is a posterior steepening. So don't be confused that back is red means there's keratoconus. No, because back float will always seem to be red and always would be this. But what you have to watch out for is that anything which is here is steep should corroborate to the area which is steeper in the posterior float. So you have to actually match this area with this area. And you should see that normally the back float is 5 diopters steeper than the anterior float. So any value that you see here, if it is steeper, like you see 47 here and 53 here, it is basically a normal thing. So you have to just watch the posterior float, but it doesn't mean that if you see something like 57, 58, then is something that we can think of. But if you have 52, 53, 54, up to 55 with not much of changes, then we can actually label this as a normal thing. Then the keratometric deviation, very important. As I said, that any deviation in the superior and inferior, anything that you see, any skewing of the axis. So a normal anterior map looks like an hourglass. A normal anterior map is an hourglass. Anything which is not hourglass, it could be inferior steepening, it could be islands anywhere of steepening, it could be a tongue shape kind of a impression. That is an defective anterior topography. So if you have here, there is no hourglass. So the first thing that you see that the topography is not okay. There is skewing of the angle of the axis. Then there is inferior steepening. There is superior inferior asymmetry, which is actually corroborating to your posterior sagittal back, which is an okay map. It is not a very important map, but it is actually to look at. Then again, the keratometric value here are almost normal. So you are not very sure that actually what should I do, that the keratometric values are normal, but the Paki, if you see, is normal, almost normal. I should not say that you can, by seeing this map, you would label this as an abnormal kind of a this. But what you have to see here is here the pachymetry at the apex and the central pachymetry should be the same normally. This is what we expect in a normal. So thinnest pachymetry to the central pachymetry should almost be the same. But if there's any deviation, like the thinnest pachymetry could be 477 and the central pachymetry could be 530. So that is when then you should have something in your mind that the thinnest pachymetry is 47. And this is what you see here. The thinnest is 513. The pupillary center pachy is 523. And the maximum K is 47, which kind of gives you an idea that there's something wrong. There's a little bit of steepening here. There's a little bit of axis that is. So what you would now like to see here is, anybody from the resident, what you would like to see the next thing? Next panel. ये वाला Yes. So this is a bad map. This is the Bellin-Ambrosio display map. So this is a bad map, which is a very important map. So only map if you are given, if you are asked for कि pentacam में एक map से आप कुछ पढ़ना चाहोगे, and if you have just one map that anybody can give you, ask for a bad map. I want to see the bad. It has ample of information to label this patient as a keratoconus. This has total elevation and of the anterior surface. This has a total elevation of the back float. Then there is a difference between the front sagittal and axial, and then there's a difference between the back. Again, it shows this is a map that this is the corneal thickness, but here you see that K1 48, K2 54. So again, this map shows that there is something wrong here in the anterior front elevation, but there is major 55, 54 Ks in the posterior elevation. So see how much is the posterior elevation, which is steeper than the anterior elevation. Again here, and the difference, back difference is up to 41 degrees. So see, you can see the difference of elevation, which is varying between anterior and posterior. And again, all these things which are represented here, always you have to see at the 5 millimeter circle. So anything which is being displayed or the information given is at 5 millimeter circle. So these maps basically tell you what is happening between 0 to 8 or 10 millimeter of the corneal diameter and the thickness which is varying this. So the cornea is thinner even in the center, 0 millimeter. And you see that this, again, this red line have a variable this. They can either have an S shape, they can actually drop down, they can have various information that you can gather. But what you have to see is anything beyond 5 mm. If it goes beyond the outer range, then you should think that there is something, because keratoconus and anything like Terriens, pellucid, these are peripheral ectatic disorders. So you have to look beyond 5 mm of the ectasia to catch any of these disorders. Okay. So here again, very important is the progression index. So what is the progression index? Actually, the progression index minimal in this patient is 1.4. So this is showing as an average of 2.2. So you have to actually see for the progression index, though it is normally in this patient, the progression index is a marker that after 6 months that you see do a pentacam, you would actually note that if the progression index has increased, then that means that this patient is getting progress. And also if this line, the graph, the thickness is reducing when you are going towards the periphery, again it shows that the patient is progressing. Next. You do not have to go at too many values that you see. So the most important here is a K1 and a K2. Then a difference between K1 and K2. Again, the cornea back, which is about 5 mm steeper, or 5 diameter steeper than the anterior surface. Then the pupillary center, pupillary apex pachymetry and the thinnest pachymetry should be almost within normal limits or should not be too much of a difference. If it is less, more than 30 microns of difference, that again is a this is there. Then the chamber volume would increase, as obvious in a keratoconus, high degree of keratoconus patients, and also the index that we are seeing. Basically, this is what you have to see. Okay. Any questions that you have? Anybody? So always look for a bad map. This is what I would say. Don't depend on the 4 maps. Always look for a bad map.
Wonderful talk by Dr. Swati, and I think all the residents should learn the basics of topography, and the previous topographers which were available were based on the principle of Placido disc and slit scan imaging, and the newer one, the Pentacam, is based on Schemplug camera-based imaging. So that's what the question they ask in exams. And there are 2-3 patterns which you should all remember. One is like bow tie pattern. So asymmetric bow tie is known for keratoconus, and another one is crab claw or butterfly pattern, which is for PMCD, pellucid marginal corneal degeneration. These are the questions they ask. And on the keratometry, if we see that the readings are more than 44, then we should be suspicious of something. Okay, and order a topography for the patient. And if the vision is not improving beyond 6/9 and it's not 6/6 with glasses correction, then we should suspect something. And if there is a doubt, if the corneal thinning is there, then we should always keep the test with the patient in record so that we can compare it after 3 to 6 months to see if any progression is there. So topography is very important tool for any refractive surgeon, corneal surgeon. Okay. Thank you.
Thank you, Ratnesh. So good morning, all of you. I am here to talk about the evaluation assessment of ptosis. So first of all, you must know what is ptosis. Ptosis, it's a drooping of upper eyelid. So normal eyelid, it covers around 1.5 to 2 mm of the cornea. And when it is covering more than 2 mm of the cornea, you call it as ptosis. There can be varied etiology of ptosis, and you might be seeing ptosis a lot. There are many people in industry also. You may have a closer look now. So classify ptosis you can into congenital and acquired one. Congenital is the one which is most common, and this is because of basically the LPS muscle dysfunction, that is a myogenic ptosis. And the acquired one is predominantly aponeurotic ptosis. The other two varieties are basically neurogenic and mechanical ptosis. So we'll see the assessment of ptosis by seeing one by one. What is the goal of evaluation? First of all, you want to make a decision for your surgery, and you have to rule out few contraindication of surgery, like in myogenic ptosis who have ocular movement limitation. You don't want to do surgery. So in the history part, first of all, you have to ask what is the age of onset. Okay, so that will tell you whether it's a congenital or an acquired ptosis, then how it's progressing. So gradual, acute means in traumatic cases or a neurogenic cases, it can be of acute onset. Diurnal variation can be there in myasthenia gravis. As the day progresses, the ptosis will increase. Change with jaw movement. Anyone? Marcus gun. So Marcus gun jaw winking ptosis is one variety. Whenever the patient opens the jaw, the lid will retract. History of trauma, other surgery and all is important for your surgical decision. Family history is important for ruling out some varieties like BPES, which has a family history, or myotonic dystrophies and other myogenic ptosis. Also, it's important to rule out pseudotosis. Okay, many times you are seeing a patient of hypotropia. Like here, you can see that you can apparently see a ptosis in the left eye. But when you occlude this right eye, or when you ask the patient to fix with the left eye, the ptosis will disappear and this eye will move upward. That means the patient was having hypotropia leading to pseudotosis in the left eye. Okay, so if you are doing a ptosis surgery in this case, it will not work and it will harm. Okay, so this is the pro forma for your ptosis workup. First of all, you have to always check vision and pupil. So why it is important to check the vision? Because of amblyopia. Okay, sometimes the ptosis may be associated with amblyopia, but remember, what is the most common cause of amblyopia in ptosis? It is not stimulus deprivation amblyopia. You might be thinking that the pupil is obstructing the way of the light reflex, so it's a stimulus deprivation. No, it's anisometroping amblyopia, which is most common in ptosis, because the ptotic eyelid, this is putting some pressure on the cornea and it is leading to some kind of astigmatism. So the anisometropic amblyopia is the most common situation. Okay, in bilateral cases, amblyopia may not be there because the patient is having some compensatory head postures like chin elevation, so he is seeing through the chin elevated position. Pupil is important in neurogenic kind of ptosis, like in third nerve palsy, in Horner syndrome, you may be having pupillary abnormalities. In Horner, you will be having miosis, and in third nerve palsy, you will be having mydriasis, non-reactive pupil. Head posture, as I mentioned, in severe or bilateral cases, the patient may be having chin up position. Okay, it's important to check the ptosis examination when the patient is at your same head level. Okay, it's not like patient is sitting, you are standing. Always ask the patient to stand up and have a same level to do the ptosis assessment. Now, frontalis overaction, how will you look for it? just check for the position of the eyebrow and for the forehead wrinkles. Okay, so on the affected side, if the patient is using frontalis muscle, there will be eyebrow will be elevated and there will be increase in the wrinkles. Then the lids. Okay, so in the lid, you have to look for the lid crease and lid fold. How do you assess for the lid crease? Ask the patient to look down and check for the most prominent crease. Here, from the lid margin, actually the brightness is too much, I guess you can appreciate. So this is the lid crease. Why the lid crease is important? Because first of all, this is your surgical incision site. Then it will tell you whether it is aponeurotic or congenital ptosis. Because in congenital ptosis, most of the time the crease is absent. And in aponeurotic ptosis, it is deep and high. Then lid fold is the dynamic lid fold. When you ask the patient to look down and then into the primary gaze, the fold which appears just above the lid crease is called as the lid fold. Okay. Then amount of ptosis is very important for your surgical decision. And to measure the amount of ptosis, you have to assess the MRD1. That is the margin to reflex distance. Now, which margin I'm talking about? The upper lid margin. Reflex is this corneal light reflex. So distance between this light reflex to the upper lid margin is your MRD1. And the difference between the MRD of two eyes will give you the amount of ptosis. Okay. And depending upon this difference, you can divide the ptosis into mild, moderate, severe. So basically mild ptosis is 2 mm amount of ptosis when your lid just touches the upper border of your pupil. Okay. So when the lid is on the upper border of the pupil, it is 2 mm ptosis or mild ptosis. When the lid crosses the pupillary border and it is somewhere between the pupillary border and the light reflex, it is moderate ptosis, that is 3 mm. And when it is crossing the center, that means your light reflex is not visible, then it is 4 mm ptosis or severe ptosis. So that is by torchlight you can assess. Okay. So if the pupil is whole visible, it is just the lid is only at the superior border, it's mild ptosis. When the lid is covering the superior border, but the light reflex is visible, moderate ptosis. When the light reflex is also not visible, it is severe ptosis. Now, always look for some compensatory lid retraction. You can see that in this patient, he is having severe ptosis in the left eye, and there is a lid retraction, scleral show on the right side. But when you lift up this eye, ptotic eye, this lid retraction will disappear. So this is because of your Herring's law of equal innervation. The patient is trying to lift up this eyelid, and because the equal innervation goes to the opposite sided LPS also, there will be compensatory lid retraction. Now, LPS excursion is again a very important test when you decide for surgery. So what is LPS action or excursion? Ask the patient to look down and then to look up while you block the frontalis. So from the maximum down gaze to the maximum up gaze, the lifting of the eyelid margin when the frontalis is blocked is your LPS action. Okay. So you can divide the LPS function into poor, fair, good, excellent. Poor is less than 4 mm, fair 5 to 7, and 8 or more is good LPS action. Okay. So this is how you plan your surgery. If you have a child who is not cooperative for the LPS action assessment, then you do ELIF test. So ELIF test is you evert the upper eyelid and you just check if whether it comes down or it gets inverted on its own or not. So if the LPS is good, then the eyelid will get revert back on its normal position, and the LPS is not good, it will remain there for a long time. Also, you can check the lid crease. As I told you, if the lid crease is good, it tells indirectly that the LPS function is good. Then vertical tarsal height, usually when you plan a Fasanella servate surgery, you do a tarsectomy. And in those cases, you have to measure the vertical tarsal height. Lid lag is an important indicator of congenital ptosis. What is lid lag? When you ask the patient to look down, normally your lid follows your eyeball. Okay, it also comes down as your eyeball moves down. But if it remains at the higher position while the eyeball comes down, it is causes lid lag. So one important acquired cause of lid lag is thyroid ophthalmopathy. And in ptosis, which variety of ptosis you will see lid lag? In congenital ptosis. Whereas in acquired ptosis, there will be lid droop. Means when the patient is looking down, the lid will fall immediately and the ptosis will increase. So this is called as lid droop. So both are contradictory. Okay, so in congenital, it will lag behind higher up, and in acquired, it will droop more in down gaze. Okay, Bell's phenomena is important because you will not want to do a ptosis surgery if Bell's is not good. So when you ask the patient to close the eye and you lift up the upper eyelids, you check whether the eyeball will roll up and out or not. Okay, and you check how much of the cornea is visible. If less than 1/3 of the cornea is visible, you say that the Bell's is good. If 1/3 to half of the cornea is visible, Bell's is fair. And if more than half of the cornea is visible, Bell's is poor, and you don't want to do a surgery in such cases. There are two phenomena, reverse Bell's and inverse Bell's, that can be asked. Reverse is the eyeball will go up and in, and inverse Bell's is down and in. Okay. Marcus-Gunn jaw winking phenomena, I told you, synkinetic jaw winking is there. When the patient opens the mouth, the eyelid will retract. That is because of your mandibular nerve supplying the LPS muscle. Okay. Okay, so extraocular movements are important in double elevator palsy. You may be having superior rectus under action. You know that the superior rectus and LPS muscle, they originate from same myotome. Okay, so sometimes weakness of superior rectus is associated. Corneal sensation, again, you have to check before ptosis surgery. If the patient is having dry eye or absence of corneal sensation, then these are few contraindications for ptosis surgery. Always ask for old photographs when you have a doubt about the onset of ptosis. Okay, if the patient is saying that I'm having ptosis since 2 years and the clinical picture looks like a congenital ptosis, ask for old photographs. Phenylephrine test is one test you can do in OPD for, especially in cases where you want to plan a Mullerectomy. Okay, when there is a mild ptosis, you put phenylephrine drop and it acts on sympathetic system. So your Muller's muscle is supplied by sympathetic fibers. So the lid will get elevated after putting phenylephrine drop. That means that the outcome will be good after Muller's resection. And one important test to rule out myasthenia in OPD is ice pack test. If you are suspecting myasthenia, you apply ice pack for a few minutes and the lid will go up. Okay. So I'll just run through few important ptosis. This is a typical congenital ptosis where there will be absence of lid crease and lid lag on down gaze. This is typical aponeurotic ptosis. There will be senile involutional changes, high lid crease, and LPS action will be good. This is a blepharochalasis ptosis. Patient will give a history of edema of the eyelids bilaterally in the morning especially, and the eyelid skin will be very thin. Okay, so this is usually seen in young patients. Then the myogenic ptosis like CPEO or CFEOM. So here you will see that all the extraocular movements will be limited. And here you don't want to do surgery, you will give crutch glasses because the Bell's is absent and your ocular movements are limited. And if you lift up the eyelid, it will not close and there will be corneal exposure. Then traumatic cases, there will be signs of trauma. Mechanical ptosis, you will see some kind of neurofibroma or tumors. And SR weakness or DP, I've already told you. And BPS, you will see the siblings and parents are also having similar picture. So management is not the part of the talk. Any questions? All right, thank you.
Thank you, Dr. Maya, for such a wonderful presentation. And it's very important to note for all the residents that if there is a case of ptosis in the OPD on the day of exam, they will definitely going to keep it. Okay, and you should follow the manner which she described. All the tests should be done and that should be remembered. Okay, so next will be Dr. Nabnita on OCT.
Very good morning to all of you. This is a very important topic given to me. To be honest, it is not possible to cover OCT or FFA in one session because it's ever emerging, newer technologies and being recruited, and the application, clinical application and understanding, they keep on changing. And we are here to discuss about very basics of OCT and FFA. And first and foremost, I would like to say neovascular membrane formation. And if this is always a bilateral situation. If this picture comes unilaterally in a younger patient, we have to think about other diseases. Now, this was in retina, just retinal cases. It has a wide spectrum application. This is one case of OCT in glaucoma. Especially in case of a very early glaucoma, we all know when the 40% of nerve fiber loss is there, then only it would be seen physiologically or field effect would be visible. But what before that? So OCT becomes an important parameter for pre-perimetry glaucoma and also for in case of longitudinal studies. Say we have a OHT patient, and we still not in the optic nerve head, still there is no changes. So we had a study which was done, it was my own thesis case, where we have seen many of the ocular hypertensive patients, there was no optical nerve head changes, but ganglionic cell complex changes, they were seen much earlier than that of the optic nerve head changes. So here we look at the parameters, optic nerve head parameters, and we can see that there are three zones. We have this green zone, then the yellow, that is the borderline, and the red zone, that is a significant retinal thinning which has occurred. So this black line, it indicates us in which situation the patient falls. accordingly we can manage. It is also important to follow up this patient longitudinally. Say after many of the patients, aged patient, they are not able to do a field test very frequently. It's very bothersome even for the person who is instructing. So OCT, it doesn't require any much dilatation. It is very less and it is easier for the older patients also. You look at the progression and then you can decide whether the patient requires treatment or the patient needs change of the medication if at all required. So these are one of two, actually these are one of from my studies. OCT is also with the anterior segment module, we can look at various factors from the anterior segment itself. We can measure if it's in case of bleb measurements, if the patient has a post-operative bleb and we are thinking that it may be failing for without any intervention, without any other modality, non-invasive way, we can measure the various internal structures that is present and we can intervene early also. This was again from one of my study, where we have found that this is the largest cyst that was there and we have measured that and we have found that the size of the wall, they are important. If it's a well loculated bleb and it tends to be healthy in the long term. We can also look at the anterior segment depth and preoperatively for any phakical implantation or we are suspecting any angle closure. In those cases, we can probably look at the anterior chamber depth also. These I will go through a very basics of fundus fluorescent angiography. It's a property of the certain molecule to emit energy for a longer wavelength when stimulated by a light of shorter wavelength. So this is how our normal fundus fluorescent angiography looks like. It was two medical students from Indiana University and 1961 they started, and with the increased time it has become more relevant. But to be honest, nowadays, the indication of doing a FFA has reduced a lot. The only few, because of it tends to cause a lot of allergies, we need to have a proper resuscitation technique and the trained anesthetist available at the center to take care of any kind of complication or allergies that may happen. So very few areas where we actually need to actually have an FFA. Most of the things are covered in OCT and the clinical picture. Probably where we are dealing with a CSR for a long time and we actually want to localize a leak. In those cases, it is relevant, and where we have a doubt whether to laser in case of vascular occlusion, and we want to know any CNP areas, extent of CNP areas, or there's a very doubtful whether there's a PDR, it's not a PDR. In those very doubtful cases, we can go ahead with this. In the CNVM cases, early cases, OCT angiography, they also help. So the indication of doing a DFA nowadays is very, very less. I'm not going to go into the very details of this. There are some very intricate, there are some excitation filters and there's some barrier filters. So let's just see how it looks like in the DFA one picture. We can never diagnose or say this is we should never diagnose. We can just say which phase it is, which eye, first of all, which eye, then which phase, and what are the and it is always a sequential finding that is more important. Whether if it's a hyperfluorescence, whether it is increasing, whether it is staying the same, whether it is reducing, those are the things that are important. And first thing we should start with it's whether there is an autofluorescence. That's the first thing we should see. Then we should look out. Then we should say, see, this is the fundus fluorescence of one eye. Say this is the right eye. This is whichever phase. This is the pre-arterial phase, or this is the arterial phase. Second plate, if you see, only the arteries, they are getting filled. The third phase, it is our AV field. In the AV phase, there are three phases: early filling, then the mid filling, then the late filling. And after 10 minutes, it's just the late staining of the disc that stays there. So if we see that this is the normal thing. So if anything abnormal that is going on, that we have to see. Say if there is a hyperfluorescence even in the very early phase, then we can see there is a neovascularization of the disc that may be happening. These are a few things that we need to see whether there is a hyperfluorescence. It can be due to a blockage defect or due to a vascular filling abnormalities. The hyperfluorescence, it can be of 4 types. It can first be of leakage, where it increases in size and intensity. Pulling, it does not increase in size. It stays the same. Initially, there's an increase in the intensity, but it does not increase in the size. It's a well-defined margin. Then there is a staining. It's a late hyperfluorescence, but size again remains the same. Then it can be a window defect. It remains the static in size and brightness. There's some RP defect because of this. This is the autofluorescence. The very upcoming, and all the retinal experts, they start with this autofluorescence. It gives us a clue about, say, the patient is suffering from chronic CSR, or there is a long-standing RPE abnormality that is taking place. To know about the nature of the RPE or what is the amount of lipofuscin that is there, autofluorescence is important. So all the take-home messages that I have already discussed that don't look at the investigation, don't look at the paper. We first have to see the patient. Look, systemic evaluation is important. Whether what we are thinking clinically is more important. This investigation, they only give us an insight. We are right about our diagnosis. Second, whatever we are planning for the patient, say we are planning for an anti-VEGF, we are right about the diagnosis. Second is you can, after some time, you can also have an idea what would be the CFT. So you can correlate clinically. Say it would be between more than 500, where my anti-VEGF is going to work. And if it's around 400, 350, where we can go ahead with our grid. So those kind of understanding will also develop. And secondly, important thing is, it is also gives us an important thing, how to prognosticate. After 3 anti-VEGFs, we want to shift our class, or we can go ahead with planning something else that we can decide. And most important, it also gives us, like in case of bacular hole surgery, it will give us a clue what would be our expected outcome post-surgery. So these 2 things, they are ever emerging, and nowadays anterior segment, posterior segment, all these technologies, they have combined and given us a more concrete idea what to do with our procedures, how to look at the OCT, and how to go ahead and especially patient counseling. That is very important. Nowadays, preoperatively, I am sure in all of our cases, cataract surgeries, we tell the patients, this is your situation. And after, say, cataract and anti-VEGF, we are expecting this much improvement. So medico-legally, it also becomes a very important step. Thank you.
Thank you, Nabamita ma'am, for the wonderful lecture. I would request the residents to move to screen number 1.
हाँ, एक प्लेटफॉर्म के साथ दे दीजिए। तब याद नहीं रहता कि लेना है, ये मेरे साथ हमेशा ही होता है। नो, वेस्ट बंगाल। তুই ওখানে দাঁড়া।
एक बार बीच में शुरू करते हैं आप, अगर मैं आपको सुना देता हूँ। कुछ तो हो, ठीक है। सारे कॉमन हो जाएंगे।
अच्छा अच्छा, बस 2-4-5 है चालू कर दिए।
हमारा नहीं इसका अच्छा अब ये बताओ आपने का पीपे वगैरह क्या बोलते हैं SIP अभी चल रही है उसकी
भी चल रही है।
है
हाँ
नॉर्मल और उसने क्या किया बीटी ने क्या किया
लग गया
ठीक है